Hi, my name is Joy Subrin. I'm a licensed master in social work and a doctor in behavioral health. I'm joining you today from Banner University Medical Center in Tucson, part of the University of Arizona and Banner Health System. I'm here today to talk about compassionate care, empathy. I'm going to weave in a little bit about trauma-informed care, all as part of our healthcare work, specifically with um, the Family-Centered NAS Care Program, which is a specialized program aimed to support women with substance use disorders. Our learning objectives are to discuss the stigma of substance use disorder, practical steps for implementing trauma-informed approach, perinatal substance use, a myth, a fact, and a stat. I'm also going to be sharing a short video from a voice from one of our patients. We're going to talk about empathetic communication and specifically the tool called validating. And I just want to reiterate that this is an overview of a very extensive topic. There are future opportunities for learning on this topic through SAMHSA, Recovery Village, Postpartum Support International Trainings, the Policy Center for Maternal Mental Health, and sherecovers.org. I just want to take a moment and have you reflect. Think about a time when you learned that a patient or maybe an acquaintance or a friend was using substances during pregnancy or during early parenthood. What was your initial thought or reaction? How did you feel? Did you have any thoughts or assumptions about the person? Maybe you had a different reaction if we said it was about a patient versus a family member or a friend. Substance use disorder in pregnancy, it affects all races, ethnicities, and socioeconomic levels. Use of alcohol, tobacco, and drugs during pregnancy is the leading preventable cause of mental, physical, or psychological impairment in children. And substance use during pregnancy, women have a higher rate of an unintended pregnancy. Maybe they aren't getting regular menses and don't know they're pregnant. Sometimes we ask ourselves why. Why do women use substances during pregnancy? Could it be from an emotional pain or physical pain, untreated mental health issues or diagnosis, family of origin? Is it a use for emotional numbing? Is it a trauma response? Is there an influence with culture, partner, family, friends? Is it due to energy level? Is it to gain acceptance in a culture? Is it to fight against loneliness or isolation? Or is it trauma? Or is it a few of these layers? Trauma-informed care has a few definitions. The one we'll be working with today is the following. Trauma-informed care considers the pervasive nature of trauma and promotes environments of healing and recovery rather than practices and services that may inadvertently re-traumatize. And the impacts of trauma could fill this page and more, but just to list a few under some specific headings, the impacts of trauma can be emotional, behavioral, physical, developmental, cognitive, interpersonal, and spiritual. And I hope you just take a minute to glance where you might see some of these challenges show up for patients of yours. To define trauma, it's an emotional response to a terrible event or a series of events, such as an accident, a long-term series of events, a sexual assault, or natural disaster. The American Psychological Association outlines trauma in the following categories. An acute trauma, which is a single traumatic event that's limited in time. A chronic trauma, an experience of multiple traumatic events. System-induced trauma, traumatic removal from a home, or an admission to a detention or residential facility, or multiple placements within a short time. And complex trauma, both exposure to chronic trauma and the impact of such exposure has on a person. And then one additional type of trauma out here to the side is secondary trauma. A person can develop secondary trauma due to close contact with someone who's experienced a traumatic event or being continuously exposed to stories of trauma, hearing or reading about traumatic events for example, healthcare staff and families. I'd like to ground this discussion by sharing a common case, very familiar to me and probably others watching today. And later, we'll dive into a real life example from one of our patients who's successfully worked through the Banner UMC um, Family Centered Neonatal Abstinence Syndrome program. This is a frequent message. Hello, Joy. I need help, please. I'm pregnant, homeless, and I have no support. I want to be honest with you. I just relapsed on fentanyl, and I'm not sure what to do. Please help me. To further discuss this and think about this case through a trauma-informed lens, I just invite you to listen for 3 minutes to the words from Dr. Dina K. Hubbard, a pediatrician and neonatologist. Just pause for a few minutes to watch.
Once you see things through the lens of trauma-informed care, it's like a superpower, and you can't unsee it. This mother had previous babies in our NICU, so she had a bit of a reputation. How she responded to the team and how she acted was outside of kind of the norm. And so I thought, I am going to set boundaries for this mother, how she interacts with our team. By the time that we were able to meet, this very premature baby needed a surgery for a shunt in his brain. And I started out by asking her, do you know anyone who's had a shunt in their brain? Much to my surprise, her answer was, yes, my mom had a shunt in her brain. She was shot in the head when she was pregnant with me. Wow, I was not expecting that. And then she went on to tell me some other traumas, being a victim of intimate partner violence, the father of this baby being murdered just 2 months prior to his birth. I thought, oh my goodness, I judged this woman that I was taking care of her baby. I recognized that I was judging instead of being curious, and it has really changed, again, how I see things. And so I mentioned the lens of trauma-informed care, and it's like putting on glasses that are a superpower. With that great power comes great responsibility.
Our patients need us. One common myth and stat about substance use disorders, recovery, and the risk of death. The myth: there's little hope for women with substance use disorders and mental health disorders. The fact is, people, families, communities, and societies can treat many mental illnesses or slow the progression. Women with substance use disorders are likely to curtail or stop the use of alcohol or illicit drugs during pregnancy. However, they are also likely to resume substance use after pregnancy. Some women are motivated to address their substance use disorder by entering and completing treatment because of their roles as mothers and/or caregivers. However, some women may fear the legal or social ramifications of engaging in treatment while pregnant and parenting. A stat to share. According to the CDC, suicide and overdose are some of the leading causes of death for women in the first year following pregnancy. This staggering statistic highlights the critical importance of maternal mental health care and awareness. This is something I say to patients, and you might say something similar. The right intervention at the right time is critical. So where do we go from here? One area that I work closely with is a program called the Family Centered NAS Care Program. This program shows our pillars of empathy, compassion, and shows our best values in terms of patient care, working towards the common goal with our patients of the best healthcare outcome. It's an evidence-based care program for the maternal infant dyad affected by opioid use disorder. And again, it demonstrates our unwavering dedication and compassion for the well-being of our mothers and babies. If we could pause for a moment, I'd love to invite you to watch just a 2-minute news clip about the Banner Health program that I know you've launched also at its beginnings. So please view for 2 minutes.
See that cute little yawning face? That's Maverick Dow. He's Kelly Dow's third child. Kelly says she was detoxing from oxycodone when she found out she was pregnant with him.
I was terrified because I've heard stories of babies going through withdrawal, and I thought to myself, what did I do here?
Kelly says she has bad knees, which led to 3 different surgeries, introducing her to opioids. But it's when she got treatment that she found out she was pregnant. And going through withdrawals can leave the baby with neonatal abstinence syndrome. It's when a newborn baby goes through similar symptoms like uncontrollable crying, vomiting, and trouble sleeping.
Opioid epidemic is everywhere, and we wanted to know, how can we make a difference?
This is Joy. She helps run the Moms Clinic at Banner University Medicine. Moms is for soon-to-be mothers like Kelly get help in easing their babies' withdrawal symptoms from opioid exposure.
From the medical model and the social work model, we needed to collaborate our teams and really start to create a clinical pathway that made it easier for patients to get care.
Every woman I know is scared when they find out they're pregnant. Your whole life changes.
Heather Miller is one of the doctors who helps take care of the mothers during pregnancy. She says providing the mothers with a safe environment is one of the key steps in treatment.
And we love seeing families stay together, and we love seeing moms find that sense of community and that strength within themselves.
Once the mother is ready to give birth, they'll have a whole team with them through the process. In a typical situation, the newborn will stay in the hospital for 6 weeks with no specialized withdrawal care. But this program has newborns staying in the neonatal ICU for only 5 to 7 days.
They're there to help you. They're not there to judge. They're not looking at you any differently. They're absolutely there to help, and whatever you need, all you have to do is ask.
Instead of giving medication, in particular opioid, to these babies, we try to have the parents, in particular the mother, as the treatment.
I was able to be there the whole time with him, so I knew he had me, which was comforting to him, knowing that his mommy's there, but I also had help of other people that knew how to handle the situation.
The end result? A happy and healthy mom and baby.
It's a scary thing at first. You don't know what the outcome's going to be, but when you look at him and see how happy he is, and he's good to go.
The anatomy of the family-centered NAS care team. If we have the ability to work together, we can help the patient bridge gaps between different service lines. The wraparound service that supports the family is what's needed. We aim to break the boundaries and redefine access and expansion of care. You're all doing that too. So just take a moment to view our team, ever growing, not any particular order, but it's power in our numbers. So what is the Family-Centered Neonatal Abstinence Syndrome Care Program? I know that your teams have launched it, so I'll just take a moment to summarize. This new approach focuses on the mother or family as the treatment for the infant. With this new method, infants are able to go home from the nursery within 5 to 10 days. We use the Eat, Sleep, Console model of care, which I'm pretty sure your team is familiar with and working with as well. Family-Centered NAS Care Program uses the term MOMS, or Mom Over Medicine, where the mom is the treatment for the baby. But the mother is not left on her own. She has the team of all of you. She's mentored and taught techniques to care for her infant on how to best manage the NAS symptoms. And one of those techniques is taught through the Happiest Baby on the Block. The Happiest Baby on the Block offers what they call the 5 S's. And if possible, prior to delivery, we invite our families to watch the video. We provide them with a link. It's also available online. It's also available at most libraries. So they have a chance to learn about the techniques prior to delivering. If that's not possible, of course, they can watch it anytime during their NICU stay. And they'll always get a copy similar to this slide that we'll call like a bookmark or a flyer that outlines the 5 S's. The Family-Centered NAS Care Program was implemented as a quality improvement program. I'd like to share some of our goals and see if they're aligned with some of yours. We wanted to impact the length of stay and improve utilization of appropriate services. It was a systematic and continuous effort to enhance the effectiveness, efficiency, and safety of healthcare services involving changes to language, changes to care, the escape model, and coordination to improve patient outcomes, experiences, and overall delivery of care. Another goal was to ensure that healthcare services consistently meet or exceed established standards and lead to better patient outcomes. To follow the research, to create a culture of safety, and to help build a clinical pathway for patient care and providers among all the interdisciplinary teams. If you're interested, this QR code will take you to the Eat, Sleep, Console Approach journal article that was published by our team in 2019. I would like to introduce you to one of our previous patients, Tawny, and her story, shared in her own words, of her experience as a woman with a substance use disorder and her recovery. Please take the next 9 minutes to hear from our patient, Tawny.
Thank you for saying that. Or did you want to take that so we could...
I do remember the first time I ever did take an opioid. I was 19. I was having back pain and I was uncomfortable, and I took a Vicodin. It almost felt like the feeling I was searching for so long. I got the house clean, I was motivated, I was happy, using those medications to not only block out physical pain, but hey, check this out, they also block out my emotional pain too. I got married at a young age. I had my first child when I was 20. Prior to pregnancies, when I started kind of getting into the pills for the pain, for the recreational use, once I found out I was pregnant, I had stopped. Had a great pregnancy, had a great marriage during it. This is probably the answer to what I've been seeking. For the emotional pain, this is my answer. Being a mom is it. I didn't know how hard being a mother was at a young age. I got prescribed Percocet for my C-section, 5 milligrams to 10 milligrams to oxycodone. We had stress from having a child, the stress of trying to maintain the house and the expectations of everybody. I was taking about 30 milligram oxycodone a day. Prescribed on the bottle is 1 every 12 hours. But I still had a job, I still had a car, I still had a marriage, and I still had a child, so I knew I had a problem, but I thought I could stop. In 2011, I found out I was pregnant again. I was heavily addicted to oxycodone at the time. I was still getting it prescribed during my pregnancy. So I used my entire pregnancy. By the grace of God, he was not born with withdrawals. I felt like I was being given all these green lights and okays to continue being an addict because it's prescribed. I was heavily addicted after he was born, where it absolutely destroyed my bonding process. I'd be out of my medication 2 weeks early, hitting up family members who I knew had prescriptions. I had gotten cut off from the doctors, and it's just a repetitive cycle, and so eventually you just go buying them off the street. I called a friend who told me she had something that wasn't quite the same, but it would take away the withdrawal, and that was heroin. It was cheaper, and it sucked me in faster than anything I ever could have imagined. Before I knew it, I was using it IV. I had lost my kids, I had lost my job, so I did IV heroin for about 3 years. So this is all in a 5-year span, from prescriptions to homeless and shooting up heroin every day, 20 times a day. I was using meth as well. Because of that pain and that guilt and that hate of failing as a mom, it just increased my addiction more and more and more. At this time, I had overdosed behind a Subway restaurant at 4 o'clock in the morning. Barefoot, and I didn't know where I was or who I was with or why the cops were there. And I caught yet another charge. And when the cop arrested me, he looked at me and said he was staring at death walking. He said, I see this every day, but I can see the pain in your eyes and the physical shape you're in. And I don't know how you're still alive, and I don't think you will be for much longer. I had lost my children. I had lost everything, and I had met somebody. That relationship ended up in an unplanned pregnancy. Terminating the pregnancy was brought up many times by many different people, and I shut it down. I don't know what happened. I don't know what clicked, but I called my mom one day, and I said, take me to an ER. I don't care where I need to go. I need to get help. I can't do this again. I won't do this again. So she took me to a hospital, and that hospital had just started a program the week prior for pregnant women who were trying to get off heroin. I was able to get off of the heroin with the medication, methadone. I had to change my whole environment, people, places, things, and it worked. I gave birth to my daughter, and I was able to keep her. She went through a little bit of withdrawal, but she was healthy and fine.
Hey, it's my friend.
How would I explain my actions? How could you abandon your children? How could you use while you were pregnant? I don't have an answer. I don't have an answer. I was really sick. This is an illness. This is a serious illness. Prior to being an addict, I judged. How the hell could anybody do that to their children? How could somebody use while they're pregnant? Oh my God, just stop. Just stop. Why can't you just stop? It affects your brain chemistry. It affects your thought process. Before you know what's happening, it happens.
I have 4 months as of today sober. For Christmas, I'm not sure. I got approved to go back home, but it's always a fear. Like, I got approved for Thanksgiving and I didn't go. You know what I mean? Like,
What's your fear, if you don't mind sharing?
I just don't. I know, like, those are my stomping grounds. Like, that's where, you know what I mean? Like, everything is, you know? And I'm not strong enough to go and not use.
Working here at the Haven is absolutely incredible. And so many times when I'm talking with somebody and it's like looking in a mirror.
He's gonna be with his dad this year, and I wish I could be with him. And last year I was going through a lot of losses with just getting out of jail, and I wanted to change it, just didn't know how. And I stopped drinking, but I still was not okay.
And I just want to shake them and tell them, it's going to get so much better. And then when I see them get better and that light goes on, and it's a really powerful feeling. And I think a lot of it is what keeps me where I'm at now. I had 3.5 years in recovery. Now working, helping other women who are in the same situation that I was in. Either lost their children or are currently pregnant and going through an addiction. This job and watching these miracles happen every single day is such an exponential part of my sobriety. It's huge. Giving hope to somebody, showing somebody that they can do it, being that role model. The biggest compliment that I'll ever receive in my entire life is when somebody says you're an inspiration. It's almost too much to take in. I don't feel like that. I have my mugshot hanging in my office on the wall to show, hey, look, it will get so much better. And it does. Now I'm currently expecting 7 months pregnant with my 4th. You don't take anything for granted anymore because you know what it's like to lose it all. You know what it's like to be in misery. You know what it's like to have nobody. So when you gain all that back and you've worked so hard for it, you have such a bigger appreciation for it. and you learn to take nothing, even the smallest of things, for granted.
So where do we go from here? Can we respond with empathy with our patients? Yes. Be part of building a culture of kindness and compassion. Meet your patient with empathy. We all have a role in empathetic engagement, but what is empathy or empathetic engagement? There are many skills that healthcare providers can practice and utilize to increase empathetic engagement. There's the skill of tuning in, perspective taking, relating, validating, and attuning, to name a few. One skill that we're going to spend some time on today as a form of empathetic communication is called validating. These are guided principles of the skills of empathetic communication. Just want to give credit to Dr. Tanya Stott with the ASU Center for Child Wellbeing. Credit her for some of her slides, and we'll move forward with talking about validating. Validating comes in 4 separate skills. It starts with acknowledgement. Can you recognize barriers, injustices, and challenges, difficulties, unfairness with your patients? So you can acknowledge those things when you're speaking with a patient. Can you affirm? Can you recognize their strengths, their triumphs, their accomplishments, and progress? The next skill is honoring. Can you recognize the validity of their feelings and their rights to have their feelings? And the 4th skill in validating is, can you give it language? Can you give language to the emotion and a meaning to their experience? So we're going to take a few minutes talking about the strategy of validating and the 4 skills to achieve this kind of experience with your patient. Just a small pause. How does it feel to be validated? Maybe you can reflect on a time where you went to a mentor or a friend or anybody in your personal life or your work world with a struggle, and they offered you acknowledgement, affirmation, honoring, and naming, or one or more of those. It's a pretty powerful feeling. Empathy and compassion are as important as medical treatments as we care for the whole person. So what can we do to become more empathetic and use that strategy in the 4 skills? We can come into the workspace being prepared, putting aside mental distractions before entering the conversation with a patient, reminding yourself of their strengths and accomplishments, reminding yourself of your purpose of the conversation. If we can engage in perspective taking as to how they might feel about the conversation or the interaction, and we can self-regulate our own emotions. So that's our empathetic presence. And that, if you look to your left, you can see the gold bars. And as we practice empathetic presentation or how we show up, those gold bars kind of meet them in the middle. So our patients on one side in the lighter gold and more in another. And the more we practice empathetic presence in our body language and our tone, we're kind of moving along into that center of the gold bar. And hopefully our patient is meeting us in the middle. What can you do to influence your empathetic communication? So that's when we start to speak, not just our presence. Minimize distractions on there again, external noise if possible. Be familiar with the culture and developmental linguistic norms of the other person. Use respectful language, roll with resistance. And again, that hopefully will help us move through those gold bars. And then what can you do to impact the connection, the empathetic connection? Allow yourself some vulnerability, professional vulnerability. If you're connecting with a feeling they're having, how can we professionally express that to offer some regulation and connection? So all 3 of these empathetic techniques hopefully move us one way on that gold bar, and also the patient feeling respected and understood will hopefully move into the middle. That might not happen on your first meeting with the patient, but the hope is that as we practice it and we continue to offer that every time we meet the patient. Hopefully they'll move along into the middle of that gold bar. Just to share a quote before we move pages, empathy is a choice. Empathy is not just a concept, it's a felt experience. Women with substance use disorders have a negative self-perception and may have poor emotional literacy to express themselves. Please think about the emotions that might be fronting when you meet a patient versus other hidden emotions that are underneath the surface that impact communication and of course, behaviors. Sometimes being curious is a helpful place to start. So I share with you these two thoughts. Maybe you've seen the iceberg analogy before, the imagery. So if a patient is fronting an emotion of anger, be curious and ask yourself, I wonder why. Is that patient really feeling attacked or guilt or nervous or exhausted? Any of those things could be the real reason, not just the fronting behavior. And I really like this quote, if you will. I wonder why, 3 words that can make space in your heart for empathy. I wonder why they're reacting this way. I wonder why they're feeling this way. I wonder why I'm feeling this way. Sometimes a little curiosity is all we need to respond with kindness instead of anger. You can replace anger with maybe being sharp or pointed, or it doesn't always have to be that we're responding with anger. But teaching our patients about emotional literacy or being aware that they might have limited emotional literacy due to trauma or substance use, it's just kind of a good framework for us to know. Empathetic communication skills are some of the most underrated skills, and they are not often directly taught in medical school or nursing school. Sometimes you'll hear them now as soft skills, but I'm not sure if that term even existed some time ago. So walking through our work and reflecting back on what Dr. Dina Hubbard shared, the neonatologist pediatrician from the previous slide, I'd like to share a few examples about how providing trauma-informed, compassionate care makes a difference. So I call this hidden shifts in language to reframe. These are some really common interactions that might ring true for you as well. And we're going to present one side as this and the other side as that. So the example is, we gave you, speaking to a patient, we gave you a bus pass so you could be back in the NICU by noon for the noon feeding. We started the feeding without you because you were late. Could that be reframed with, welcome back to the NICU. We wanted to keep you updated that we started the feeding an hour ago. How's your day going? Did the bus ride go okay? Would you like to meet with a social worker to review how to use the bus system? Can I enter the NICU phone number on your cell phone? You're welcome to call with us with any updates. There was a lot of curiosity. There was a lot of validating. There was just a lot of exchange there. So that's one example of how we answer the question and speak to the patient while also maintaining empathy. Another this or that. If I tell you about my drug use, you're going to call CPS and they're going to take my baby from me because you think I'm a bad mom, even though I have been working hard on my sobriety. So here's the skills validation. I hear that you are fearful and it really hurts to feel like you're being judged. That's the skill of acknowledgement and naming. You have made strides, that's affirming, and your efforts are noticed, that's honoring. If you can talk about your substance use history, like being trauma informed, it will help to take care of your current needs and help us take care of your baby. One last example for this page. The patient has refused to enroll in an MAT program versus at this time, the patient has not yet enrolled with an MAT and is not participating in outpatient services. A few other familiar examples. The baby is addicted to the same substance as mom. The baby is born addicted. Versus the baby was born to a mother who used drugs while pregnant. The baby is or will show sign of withdrawal from perinatal drug exposure. We are caring for a newborn who was substance exposed to substances. Babies cannot be born with an addiction because addiction is a behavioral disorder. They're simply born manifesting a withdrawal symptom or a withdrawal syndrome. Just to pause Women with substance use disorders may have a more difficult time with adjustment and trouble adapting to their new role of motherhood. But with support, they can create many behavior pattern changes. One more this or that. You just informed a patient that her baby is experiencing withdrawal and you describe the symptoms. You also tell the patient there is no reason to be overwhelmed. You knew this would happen. Versus, you just informed a patient that her baby's experiencing withdrawal symptoms and you describe the symptoms. You also tell the patient, I understand if you're feeling overwhelmed. I want to help you understand what is happening now and how we can work together. The second exchange recognizes the emotion, builds trust, and invites connection and suggests an action plan to work together. That's pretty powerful. Together, connection and validation create empathy to help others feel heard, respected, and more willing to connect. The importance of words and language. Our body interprets language through the lens of past experiences. Common phrases can unintentionally evoke distress and defensiveness. Reflect on what emotions and what physical sensations may arise for you as I read these statements. So take a moment. What's arising for you when I say, we'll be meeting alone today? You failed. She refuses to get help. Your payment is due today. This is urgent. Why didn't you just leave the relationship? In trauma-informed care, mindful language fosters safety, trust, and connection for both the patient and professional. Since we're not meeting in person today, I just invite you to think about how some of those common phrases made you feel, if it evoked any unintentional physical or mental stress or distress. Just 2 articles that you can certainly visit in the future about how words matter. I'll pause here to allow you just 3 minutes to watch a video about empathy versus sympathy by Brene Brown.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
The first step, which may happen automatically for the healthcare provider, is often to support their patient. This can be done through, first of all, recognizing that there's a trauma response happening and responding by offering support and regulating their emotion. You can think about the example from the video just a moment ago. That might be done through grounding, mindfulness technique, body language, attuning with the patient, kind of like what you saw in the little example. And the sequence of engagement does follow a pattern. The first is to regulate, focus on helping the patient achieve a state of calm and stability through sensory regulation. And I think we saw that in that little example. Establish a connection to build a relationship, crucial for emotional safety. And then reasoning. Cognitive reasoning can take place, allowing for problem solving, higher level of thinking, and moving back into what we would call the window of tolerance by Dr. Siegel, which is a more functional state of your nervous system. How does this all align with trauma-informed care? How can we infuse principles of trauma-informed care to benefit our patients and put these pieces into practice? For some of you today, you may have walked this path before, but some people are beginners. We'll just take a moment to outline the 6 principles of trauma-informed care. Safety in physical setting and interpersonal interactions, trustworthiness and transparency, peer support. Can you offer some follow-up with a peer recovery group or even a program online or a helpline? Is there collaboration? Are you partnering and leveling the power differences with your patient? Is there empowerment? And some of those examples, I tried to really weave in empowerment and strength. So is the individual's strengths and experiences being recognized and built on? And does your organization move beyond stereotypes and biases? I'm shaking my head because I know that we are. This is just an example of how we want it to be. We set a goal and we achieve it, versus maybe the reality for our patients and sometimes for ourselves. We set a goal, we're learning, we're doubting, we're practicing, we're failing, feeling lost, we're getting it, we're struggling it, and we're achieving it. The only thing that's missing are people along the way, like you, who are helping that person achieve their goal and not get lost in all of that unwinding. Our work lives can be challenging, stressful, difficult, and also very rewarding. We often get a sense of worth and accomplishment from our work and the role we play in the lives of our patients, a multi-generational change. But how do we navigate the demands while remaining self-compassionate and compassionate to our patients? As healthcare providers, remember our purpose can be inspiring and protect us against compassion fatigue. And I just pause for a moment for a think and reflect moment to remind yourself of your purpose. Just want to share 2 quotes, pretty famous quotes. Maya Angelou says, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And an unknown author, I finally found my rhythm when I realized that even the steps backwards were part of the dance. Changing the culture of healthcare in a few key thoughts. Patients' health is more likely to improve when healthcare services are in partnership with patients, families, and community resources, ideally leading to positive outcomes for mother and baby. And I know that's why we're here today. Healthcare providers have the abilities to be connectors We hold special sets of knowledge and skills to take the best evidence and put it into practice to improve care of patients, especially critical, high-risk, vulnerable patients. I like this idea, improving healthcare is a contact sport. Just meaning we need to work together and carry some of the weight together and shift when we need to. Our job as healthcare providers is not only to provide care, but to improve it. And I know all of you sitting here today are doing that work. Some resources just to share if you're not familiar, a few books that have been helpful in our learning about substance use disorder and treatment, a few documentaries, one that I just learned of recently, Song for Charlie, a few web pages to share. Just a moment to share about the Maternal Mental Health Echo that's offered through Be Well Texas. You're welcome to register through that QR code. And in closing, if you have an idea of how to improve patient care, share it. You can champion change. Collaborative care is very powerful. Be willing to do a Plan, Do, Study, Act, or a PDSA change model to work towards a quality improvement goal. Use evidence-based screening tools and data to support your interventions. And take care of yourself. Thank you for all the work that you do and letting me share something I'm passionate about. And I know those of you watching today are passionate, empathetic caregivers and providers. Just to end with this quote, we are called upon, it often seems, for unreasonable requests at unreasonable times. We often later judge to be the finest hours of our days. Thank you for the extraordinary work that you do with patients. I'll share a few resources.